my privilege to introduce Dr. Iman Baroum. I think everybody knows Dr. Iman here. She's a radiology consultant interested with women imaging.
Yes.
Taking care of screening program in Jeddah and I think here. And she will talk about mammography screening program in Jeddah. تفضلي دكتورة.
شكرا دكتورة فاطمة. I'm glad to be here for the second time. I came before and visited this nice place, مركز طيبة. Really, they're doing good job. So we are completing the loop of the morning lectures. Dr. Fatima, she threw an extensive, she gave us an extensive talk, which is really what we're doing in our real life. Now I want to draw your attention to the screening. I'm focusing on the screening, and we are showing the importance of the primary healthcare physicians. So actually, we started our Jeddah breast cancer screening pilot program. Next, please. The program development, it came from that we studied the, next please. كان ممكن أحرك أنا من هنا بالرايت ولا اللفت؟
لا من هنا.
هذا اوكي. طب ولما ارجع باك معلش السبيس فورورد وباكورد باك. Okay, so we started how our program developed. We studied the regional and international statistics that signifies the importance of the presence of breast cancer screening program, i.e. what is the justification of early detection of breast cancer. When you say I want to do a breast cancer screening program, when you go to the higher authority, this is, they put you in front of you a lot of question marks. The first one, does it cost effective or not? This is what they care about, the first thing. So we studied the statistics, and we conducted workshops with leading companies in breast imaging to throw light on the workflow. If you want to do a program, you have to know how this program is going to work, and you have to know it step by step. This was, we started our workshop with GE company. I'm not advertising for anybody, but this is actually, they have the intention, and we started with them. And this was in January 2010. The workshop, when you say I want to conduct a workshop, you are talking about a multidisciplinary approach. You are talking about radiologists, surgeons, oncologists, pathologists. Those are the core people in any breast management. You have to have these 4 people on one table. So, and then you have to bring all the leading personality in your region. They should sit and understand what you're talking about. So we conducted a workshop with the presence of the director of Jeddah Health Affairs and all the directors of Jeddah hospitals. I'm talking about Ministry of Health hospitals, and the medical directors and all heads of department involved in the multidisciplinary approach, which is the pathologists, radiologists, and surgeons. And the most important is the director of the primary healthcare services, the most important person, to discuss the magnitude of breast cancer burden in Saudi Arabia and the importance of screening program and outline the infrastructure. Again, if you want to establish a new program, you have to know the workflow, and before the workflow, you have to know whether you have the proper infrastructure that help you in conducting this program or not. This was in March 2010. And the decision was to start the Jeddah breast cancer screening pilot program. So I'll review quickly the justification of breast cancer screening in Saudi Arabia. Breast cancer is an important health problem. You will hear these again and again and again to understand the magnitude of the breast cancer. Breast cancer is an important health problem. It is the most commonly diagnosed cancer globally throughout the world, including Arab world and Saudi Arabia. According to the Saudi Cancer Registry, the incidence of breast cancer among all cancers is 21 to 25%, which is a hell of a lot. And about 1.3 million women will be diagnosed with breast cancer annually all over the world. Around 500,000 will die from the disease. And unfortunately, 55% of the mortality from breast cancer occurs in the developing countries. According to the Saudi Cancer Registry, 98% of breast cancer are locally advanced at the time of diagnosis. No wonder we don't have any early detection, very well-established early detection programs. We don't have screening programs, so usually the ladies, they come with late presentation. So 98% of the patients, they come with locally advanced. Locally advanced, this means a mass more than 3 centimeters and with regional lymph nodes. And the number of breast cancer cases has been doubled in the last 10 years. Dr. Izzuddin Ibrahim and his colleagues, they did a study. It's just a statistical model. They studied all the previous statistics, and then in their study, their vision is to see the future of breast cancer in Saudi Arabia in the coming 15 years. So their conclusion was, there will be an increase in the number of breast cancer cases by 350%. And the death rate from breast cancer will increase by 160%. This resembles a tsunami. So Saudi Arabia should be ready for this sudden increase in the number of cases. This increase is due to aging of the population. Because now our population is young, after 15 years, the majority will become elder. When I say a tsunami, this means something with a huge magnitude that it comes all of a sudden. So if you prepare your primary health physician, you prepare your surgeons, everybody is prepared in a way that we are managing breast cancer in a proper way. So it won't be a surprise, and we can handle that. Adding to that, we should have the proper facilities for that. It has been proven all over the world that the death rate from breast cancer has been reduced gradually since the year 1990 with the introduction of breast cancer screening programs and early treatment. So the entire world has started breast cancer screening since 1990. This is again all these studies that are confirming that breast cancer screening is an important tool. If you notice this, the distribution or the mortality, the incidence of mortality, the three red highlighted with red, this is Sweden, UK, and Australia. I'm highlighting these three countries because these three countries, they have well-established nationwide breast cancer screening program. And if you can see, the mortality in Sweden is 0.34, UK 0.31, and Australia 0.25. And in spite of these figures, they have their well-established screening program. And for Saudi Arabia, the figure is 0.43. So this means that we deserve a screening program if we compared our figures to the others, because it's the highest. So breast cancer is an important health problem throughout the world. The question in this millennium is how to start a nationwide breast cancer screening program, because we have all the evidence that indicates we need a breast cancer screening program, and not do we need such a program. We finish from this question. We need it. So if you want to start a program, you have to have your inclusion criteria, whom you are going to invite to this program. So our inclusion criteria is a Saudi lady. Again, it's not a racism that we want a Saudi lady, because if you do a mammogram, it's an easy thing to do a mammogram for anybody. The problem is when you discover a patient with cancer, you do a biopsy, and it's proven to be breast cancer, you're stuck with the treatment, because it's expensive and has a lot of logistics for non-Saudis. So from the beginning, we are including Saudi ladies. The targeted age group, as Dr. Fatma said, we should start from the age of 40 until the age of 69 or 70. In fact, there is no limit for the upper age, as long as the lady is in good health and she can tolerate treatment, whether medical or surgical treatment, so you continue to do screening program. So actually there is no limit for the age, if she's not having any comorbidity. So why should I stop her from providing this? So if we counted Saudi ladies between the age of 40 and 69, we found that our targeted age group, the number of such cases is around 225,000 in Jeddah region. I'm talking about Jeddah. So in our pilot study, phase will include only 5%, meaning 11,000. And we plan to do screening every 2 years. Because when you have shortage in manpower, meaning of the manpowers, you have shortage in the technology and the resources. including the technologists, including the reading radiologists. We don't have a lot of radiologists to do mammogram, to read mammograms. So if you are going to do it every year and you are increasing the number, and the ladies will hear from each other, and then the number is accumulating every year, so you will end up that you are delaying the reports, and this is not good. This slide, it shows our activities in Jeddah region. We started with the short campaigns, and then we end up with this program. Again, in other Arab countries, they have their established screening programs for the breast, like in Lebanon or in Jordan. And these are lower income countries compared to our country. So phase 1, the goals in our phase 1 Jeddah breast cancer screening program is to do public awareness sessions about breast cancer and encouraging early detection through self-breast exam, clinical breast exam, and screening mammogram. We had a mobile mammogram unit, which is a contribution from Siemens company in collaboration with MOH. I'll tell you something. Before, I was against starting a mammogram with a mobile unit. This is my own thoughts. I said we start in a very well-established place, like in the hospital. But when I had experience with a mobile unit that you can put it, you can take it to the people, and you don't force the people to come to you, this is easier for them, and you can collect larger number of your target group. So the idea of having mobile units for screening is really a successful idea rather than static units. The mobile unit was moving between 3 primary health care centers at different regions in Jeddah, in the north, in the east, in the west, for a period of 3 months, starting from October 2010. 3 months طبعا هذه كان داخل فيها الحج، إجازة الحج وكذا، فبس هو actually I'll show you what are the working days. So our primary health care was Al-Hamra, and this is the number of participants and the percentage of participation. So from Al-Hamra Primary Health Care Center, we have 511 clients. Al-Safa, around 500. Al-Mahjar, only 157. So the total number of participants was 1,167. So this slide will teach us that choose the proper primary health care center that you are going to put your mobile unit. First of all, it should be busy with clients, busy with patients that are coming for everybody, for the medical checkup, for the dental, for everything. Busy primary health care center. And the other restriction is that you have to have a good parking area for your mobile unit. All these limitations led us to use Al-Mahjar, in spite that it was low recruitment. This is our mobile unit. Actually, it was at Al-Hamra Center. This is inside the mobile unit. I think if you can have a chance of going inside the mobile unit, this will be a good experience. What is the workflow inside the trailer? The trailer is the mobile unit in our scenario. First of all, at the entrance of the lady to the trailer, there is a reception. At the reception, she has a receptionist which do electronic registration. We have a form for electronic registration. And she give a client a serial number form written on it, her name and the national ID. In any screening program, you have to have a fixed number that the lady, if she was in Jeddah or in Sharqiya or in Medina, she used the same number. So there is no duplication of the examination. If you are going to use a medical number that is used in some hospital, so the examination definitely will be repeated in other hospitals in the same city, not in other cities. So the national ID is the only number that will not going to be similar for any other patients. And then the primary healthcare, the beauty is that we have a primary healthcare physician on the trailer itself, which is, from our experience in Jeddah, this is very healthy and very good way that it adds a lot to the program. She do the clinical breast exam, and she fill an electronic form. In fact, the electronic form is all the predisposing factors that Dr. Schneider has mentioned in his lecture. All the predisposing factors for breast cancer. And it shows the appropriate icon and the serial number, whether it's diagnostic, screening, or no mammogram for that lady who entered the trailer. And then she go to the technologist, which will feed the client data in the mammogram machine. If S is selected, she will do the mammogram. The technologist will finish the procedure and tell the lady that she will be informed about the result after 8 to 10 days by phone. So this is the piece of paper that is given to the client and filled by the receptionist, national ID, name of the patient, and then if the lady, in fact she's not a patient, she's a lady. If she's not having, by questioning from the reception, the receptionist, they have few questions. Are you pregnant? Do you have cancer? What's your age? Are you Saudi? So this is the first filtration is at the reception. If she doesn't have any of these things, so she will encircle for screening. And then she will send her to the primary healthcare physician. This is the registration form at the reception on the trailer. It's just simple. Serial number, patient ID, name, age, telephone number, from which primary healthcare, etc. Of course, the mobile number is very important tool here because we are going to rely the results through the mobile number. And we don't have other tools. We don't have fax. They don't use email. They don't use mails also. So the mobile number is the most useful tool. And this is the access sheet that the primary healthcare physician on the trailer has this program on her notebook, and she's filling it for every patient instead of writing in papers. And at the end, this access sheet can be converted into Excel sheet, and it will give us statistics easily. What is the reporting workflow? We use this form for reporting, and the standard reading of screening mammogram is blind double reading. The meaning of blind double reading is that two radiologists will read the same mammogram and they are blind to the result. They don't know what the first one has read, so they will not be biased with the results. So if they agree, we are using again the same BIRAT category Dr. Fatma talking about, because this is the standard reporting for mammogram nowadays. So either they choose, so BIRAT 1 and 2, they are normal. 3, 4, and 5 abnormal means need further investigation. So if reader 1 said 1 and the reader 2 said 1, so the patient will go to routine recall. If they said it's 3 or 4, she means further investigation, and then we will recall the patient for further investigations. Further investigation of suspected cases and their clinical examination were carried out in our hospital, in King Abdulaziz Hospital, and our recall rate was 14.8%, which is quite high. Assessment of further investigation, we did the further investigation. Further investigation meaning the patient might need an ultrasound, might need compression view, further mammographic views, or biopsy. So all these further investigation are done in our hospital. So after you do invasive procedure for the patient, you cannot send her home. She should be seen by a surgeon, even if the biopsy is benign. So we sent her to the assessment clinic in King Abdulaziz Hospital and in King Fahd Hospital. What are the results and performance indicators? Whenever you do any program, you have to audit your program, and you have to set for yourself some indicators that will tell you, I'm doing fine or I'm not doing fine. So for breast cancer screening, generally these are the indicators. So what is the total target population for this phase? From the beginning, we decided that we will include 2,000 clients for one reason or another. So if you set up your target as 2,000 clients, you have to see, did you reach to your goal or not? And the total number screened was 1,167, and the total period of screening was 58 working days. So over 2 months, we screened around 1,000 patients. The uptake of the program, I said my target is 2,000, and I did only about 1,100. So the uptake of the program is 58.3%. The minimum accepted throughout the world is 70%. This means I'm not recruiting enough number of clients. And the mean age was 56.7. The recall rate, 14.8. The acceptable is less than 7%. This means we are calling so many patients, and this means The readers reading the mammogram, they are not experienced enough, they are not seeing so many screening mammograms, because we radiologists, breast radiologists all over the kingdom, we don't have screening programs, so we are seeing limited numbers of mammogram, which is the diagnostic. Unlike the other countries in Europe or UK, they're having screening mammograms, so they are seeing per year 5,000, like 5,000 mammograms. يعني احنا اكثر واحده فينا يمكن ما شافت 2000 3000 طبعا غير دكتور فاطمه لانها she's doing screening mammogram وسميره. Our biopsy rate was 2.7%. Our cancer detection rate was 0.59%, which is high. Invasive cancers, all were the discovered cancers. All of them were above 1.5 centimeter, was 57%, and DCIS cases was 42.8%. So the total number of cancer cases detected 7, and the cancer detection rate was 0.59%. Post-screening mammogram assessment standards. We have to assess our mammograms, our reporting, the timing of the reporting, everything has to be calculated to know you are doing a good job or not. الخط صغير معلش شوية. Screening mammogram results sent within 2 weeks from screening. يعني أنا عملت اليوم الماموجرام within 2 weeks الست تبلغت بالنتيجة. هذا كان 76%. Screening mammogram results sent after 2 weeks was 23.5%. The interval from screening mammogram to assessment. كل اللي قلنا لهم في recall. We need them to come back. Interval from screening mammogram to assessment after 3 weeks was 47%. Time of biopsy result less than 1 week was 93%. All the patients we have biopsied, we get the result of the biopsy in less than 1 week. This is the majority of our patients. So our pathology department was doing excellent job. The time of biopsy result more than 1 week was only 6.2%. The interval from biopsy to surgical assessment, 2 weeks and less. The majority of our patients were seen in the surgical clinic after the biopsy, and only 6.2 more than 2 weeks. So I think we're doing fine in taking care of the patients. This is the BARAD categories, the results of our 1,167 patients. BARAD 1 and 2 are the normal. So the majority was BARAD 2. BARAD 2 means normal, but she has a normal finding in the breast. BARAD 3, 4.7. BARADs 4 and 5, which is suggestive of malignancy, it was 0.9 and 0.3. The biopsy cases, malignant versus benign. The benign biopsies were 78, and the malignant was 21. By the way, this is natural. The majority of the biopsies should be benign. We did a comparison between our program and some of the screening programs in the kingdom, which is published in the medical journals. This is Jeddah, and this is Al Qasim and Al Abd Al Latif. Within 2 months, we saw 1,167. Within 1.5 years, they saw 1,700, and Al Abd Al Latif 1,200 in 8 months. Anyhow, I don't need you to go through the details. The message is, whenever you do a structured screening program, please publish your results frequently. We have some points of weaknesses in our program, which is low program uptake, i.e. we targeted 2,000, we didn't get that. Our uptake was 58%, and we have a high recall rate, which was 14%, it should be less than 7. So how we correct ourselves? We convert to higher program uptake by better public awareness and better communication with primary healthcare centers. They are the recruiting force. You are the recruiting force. The use of mobile units as primary healthcare centers, we have to choose the proper ones. And convert to a lower recall rate program by changing low volume readers to high volume readers. I'm targeting the radiologists. We have to conduct workshops for radiologists to read screening mammograms. We bring a workstation, we put like 500 cases of mammogram, and I let radiologists sit and read it as if they are reading it in real life. So you train their eyes. And by series of regular multidisciplinary scientific activities, At last, the dream came true. Phase 1 national screening program has launched in Riyadh in December 2011. They're using mobile units. So everybody knows that we have a national screening program in Saudi Arabia, started in Riyadh. The message to my colleagues, breast radiologists, which is today actually, I should have a message to the primary healthcare physicians, so I'll skip that. Message to my colleagues, directors of regional breast cancer screening programs, we have to unify the inclusion criteria, and we have to unify the used forms, and we unify the program performance indicators, and keep your program strictly audited by clear assessment standards, and publish your work. لأنه إحنا بنتعلم من بعض. يعني لما أنا أشوف الدكتورة فاطمة إيش سوت، أنا بتعلم منها أشياء كثيرة. Be sure that you have at least one breast assessment clinic that runs once or twice a week. If you are talking about a screening program and you want to discover a larger number of patients, you have to have a well-established assessment clinic in one or two of the major hospitals in your region. The assessment clinic means the radiologist will do all the necessary investigations, whether invasive or non-invasive, imaging or non-imaging, and then a surgeon should be ready to see these patients. The problem with those patients, you cannot give them appointment within the usual appointment. It should be delayed after 3 months or 2 months. هتقول لك أنا كنت قاعدة كويسة في بيتي، جو قالوا لي عندك الشيء الفلاني ومدين لي موعد بعد 3 شهور، عمالي حطيتها في قلق أنا. إحنا عادة هذول نديهم priorities، نحط لهم عيادة لوحدهم، نسوي لهم عيادة لوحدهم. You have to have a regular weekly breast multidisciplinary. Again, this is an international attitude. When you have a breast service in your hospital, you have to have an MDT meeting, multidisciplinary team meeting for the breast, where all the biopsied cases, the positive cases after biopsy should be discussed in that meeting, where there is a surgeon, pathologist, radiologist, oncologist, etc., deciding how to manage that patient. And then the result of this meeting should be documented in the patient file, that this patient should have this kind of treatment. ما بيمشي. So we have to form a union and let's meet regularly. So today it's a chance to make this union. So your region will be ready to hook with the national screening program. We are doing a lot of work in our regions independent of what the Ministry of Health doing in formality. So we have to talk the same language in order to hook to each other. يعني نمشي على نفس الكرايتيريا عشان نقدر نسوي واحد program في النهاية. So we have to be together. Thank you very much.